inviting me. I'm Sujoy Mukherjee. I'm a consultant psychiatrist. I work in West London. And also, I'm the national chair of the Memory Service National Accreditation Program, the Accreditation Committee. I'm involved with the European Association for Royal College. Today, I know sort of the caption of my talk is slightly different, but it's essentially the same. I'm going to talk a little bit about the new developments on the treatment of Alzheimer's disease. Next slide, please. So just a quick recapitulation that when we talk about, when you use the term dementia, the dementia often equates with memory because the first thing we think of dementia, it comes memory in our mind. And that's true because the commonest sort of problem in dementia is memory problem. But what we need to remember is dementia is actually a complex neuropsychiatric syndrome, which is way more than just memory disorder. And if we think of dementia, we are thinking at least these three particular domains in people's life. And one, when you use the term cognition, it obviously incorporates memory, but it also incorporates other components of cognition, like language, like attention concentration, like planning, organizing, all these kind of different things our brain does without us even being aware of it. So dementia is what we call a global cognitive impairment. It's way more than just memory disorder. And it's not just about the cognition. We know if people's cognition gets impaired, that will impact their function. And that is a very important criteria about diagnosing dementia, and particularly differentiating between dementia and other conditions which are milder but kind of can progress to dementia, what we sometimes call as mild cognitive impairment or mild cognitive disorder. So the functioning of daily life and of everything is very important in terms of assessment and also management of people living with dementia. And it is a complex issue because functioning is very individual. It has got its cultural and familial connotation, and sometimes function can be affected not just by cognition but also physical problems, mood, all kind of things. So that puts us a diagnostic and management challenge. And the third domain is also equally important, and that's where we call it a more neuropsychiatric syndrome, is behavior. And we use the term what we call behavioral and psychological symptoms of dementia. And dementia as a condition affects a range of behavior, starting from apathy to mood changes to aggression to psychotic symptoms, to name a few. So just to emphasize that really, that it's a much bigger an issue rather than just memory disorder. Next slide, please. And we know there are different types of dementia. We are going for this talk, we are going to talk mostly about Alzheimer's disease. That's the one where the most of the developments are happening in terms of treatment. And often, people ask this question in the clinic, what is the difference between dementia and Alzheimer's? It's a very common question. I think what is important to remember, dementia is an umbrella term. So dementia incorporates different types of dementia. By definition, all it says is that somebody who has got impairment of at least two of the cognitive domains, maybe more, a global impairment, and also significant impairment of their function. Often that is also associated with some sort of behavioral changes. But Alzheimer's disease is the commonest type of dementia with a characteristic change in the brain and the brain chemicals. But there are other types of dementia like vascular dementia, dementia of Lewy bodies, frontotemporal dementia, and so on. So that's the difference really. The dementia is an umbrella term, and Alzheimer's disease is the commonest type of dementia, and that's where the memory is the primary cognition which gets it. Next slide. So what happens in Alzheimer's disease? Alzheimer's disease is a brain disorder. What happens is this, in this picture you can see there is a normal brain cell, and then you see an abnormal brain cell. And there are two little things. One is called amyloid plaques, and one is the tau tangles. These two are hallmarks of Alzheimer's disease. Amyloid is a normal protein which is in our brain, and sometimes this amount gets more as we grow older. What happens in Alzheimer's disease is the amyloid production gets much more, and also they get abnormals. They start clumping together outside the cells, and they are referred to under the microscope as amyloid plaques, and they start killing the brain cells. And that's one of the hallmarks, and we'll refer to that as we go later about the treatment. The other problem is tau, which is again another protein, which are intracellular inside the cell, and they normally remain in what we call microtubules inside the cell. What happens is also tau gets abnormal, and when the tau starts making like a line, and we call them neurofibrils. And these are, or neurofibrillary tangles. These are classical another pathological abnormality in Alzheimer's disease. Now, what we don't know, though there are a number of hypotheses, why these two particular abnormalities happen in Alzheimer's disease. But these are the classical hallmark. But when we do MRI scan, or when we see the brain in a broader sense, we see the brain is shrinking. And also there are particular areas of brain which shows disproportionate shrinking. Now, mind you, a brain shrinking, a bit of shrinking is normal with aging. So sometimes this differentiation is not easy because we obviously can't see the brain cells under microscope in a living human being. Next slide, please. Oh, what happened to the slide? No, I think we are missing a couple of slides. Can you please go back and try? What's the problem?
Yeah, problem looks like we're on a snow white app.
Yeah, they appear blank.
Okay.
Because I asked, let me try once. That's strange. Shouldn't come as blank. Is it any better?
I can see one that says what medications are used to treat Alzheimer's disease. That one's up.
Yes. Can you see that?
Do you want to talk? You want it to, and then
Yeah.
you get
So what basically, okay, I don't know whether you can see it or not, but at the moment, the treatments, we have got really two different types of medication that we use in people with Alzheimer's disease. One of the treatment is what we call cholinesterase inhibitors, and there are three different ones: donepezil, rivastigmine, and galantamine. Now, these treatments, what it does is not actually a cure. One, what happens in Alzheimer's disease from a chemical point of view is that we have different neurotransmitters in the brain, and one of them is called acetylcholine. And that acetylcholine level in the brain goes down because that is highly concentrated in what we call the memory area, which is hippocampus and parahippocampal structures, some structures, particular structures in the brain. That chemical goes down. So we have no way of pumping that chemical from outside to inside the brain. It wouldn't go because of something called blood-brain barrier. So what we do, we give these tablets, and what they do is they reduce, or not stop quite, but reduce the breakdown of the chemicals. So that means whatever acetylcholine is left in the brain would hopefully work a bit harder. So you can imagine that only works in the earlier part of the dementia. So that's why these medications are probably most effective in mild to moderate Alzheimer's disease. And in that, it is not curing the underlying cause, it's just trying to fix the effect. So often, actually, the response is modest, and probably 1 in 3 people respond to some extent. It doesn't reverse the process. The second group of drugs is what we call memantine, which works in a very different way. It works on another neurotransmitter called glutamate. And that's the cholinesterase inhibitor. Can we have the next slide? So this is another drug called memantine, which is often used in combination with the previous one, the cholinesterase inhibitors. Now, memantine works on another chemical system called glutamate. These glutamates, they are toxic. They are toxic to brain cells. And the memantine tends to control that glutamate level. Initially, when memantine came into the market, it was thought that this is a drug which is going to modify the disease process, or not even cure, but kind of do some reversion. Unfortunately, that has not happened. So it is another drug which kind of fixes some of the problem, but doesn't really change the underlying pathological process or disease process. But the advantage of memantine is it seems to be more effective in behavioral disturbances, which sometimes are very difficult to manage. We have heard about the use of antipsychotic, the problem with that, and often other drugs that we use like trazodone or benzodiazepine bring in their own problem. So memantine is quite effective in terms of managing behavioral problems, but it may not have as much effect on memory like the cholinesterase inhibitor. And because the behavioral problem often happens when the condition progresses, so more often than not, we use memantine in people with moderate to severe degree of dementia. The good news is this drug, if chosen correctly, is pretty well tolerated compared to many other drugs. So a combination of donepezil or any other cholinesterase inhibitor and memantine sometimes are quite effective to manage people in a reasonable way without over-sedating them or without increasing the risk of falls. Next paragraph. Sorry, next paragraph, next slide, please. Now, what the scientific community has been struggling with dementia, particularly Alzheimer's disease, for more than 2 decades is they were trying to find out some sort of a cure, or what we describe as disease-modifying agent, which can target the underlying pathology. But it has not been successful. But more in the last few years, things have changed. Now, there is a new group of treatment called monoclonal antibodies. And these are a group of proteins, these are antibodies, they are given from outside. And what the studies have found recently is that they are very good at clearing the amyloid. Now, there are different hypotheses why Alzheimer's disease happens. And one of the key hypotheses is what we call amyloid hypothesis. You remember we talked about those amyloid plaques, those amyloid getting in our brain and forming these clumps and killing cells. So if you reduce the amyloid, either before they form the plaque, or if you reduce the plaques themselves, then the argument is you actually reduce or stop the disease process progressing. And that's the hypothesis behind monoclonal antibodies. But the problem with the monoclonal antibodies is they are not simple, they are not tablets, they are IV infusions, and they have their own problems as well. But as you can see in this picture, different drugs work in different ways. So the antibodies, some of them actually, they go and they pick up with plaques and they remove plaques. Some actually, directly clump with amyloids and remove amyloids before they form plaques. Or they might stimulate the body's own immune system, and that immune system then go and remove the amyloid plaque. But at the end, the result is that it reduces amyloid. But the key criteria of this treatment is somebody who has to have a lot of amyloid and amyloid problem in the brain. They are the right ones. And also, it has to be demonstrated that actually their amyloid is going down. At the same time, their cognition and functioning are improving. So these are the underlying issues about the treatment. We'll talk a little bit about the treatment next slide. So this is what the treatments are, which is causing quite a bit of a media storm recently. Now, as you can see, they have made a bit of tongue twisters with the names. So it's aducanumab, lecanemab, and donanemab. So these are the three drugs. The first one, which was approved in USA in 2021, and then the lecanemab and donanemab is the most recent one, which is still application is pending with the FDA, which is the Food and Drug Administration in USA. Now, the thing is that aducanumab was the first kid in the block. And I'm not going into all the details of the research findings, but it seems the data is actually getting better and better. So donanemab has better efficacy data and better data in terms of clearance of amyloid, but also improvement in various scales compared to aducanumab. And to reflect that, aducanumab actually has recently withdrawn their application from European Drug Agency. So that drug is kind of out of the way. I don't think it will ever come to the UK. But the two focus at the moment are lecanemab and donanemab. And so at the moment in USA, both the aducanumab and lecanemab are approved for particular cases. But also, as far as I'm aware, the only other countries which have approved them is Japan and China. But I don't know whether China has approved all three. They are yet not approved in Europe and UK. They are being evaluated by the agency. So in UK, how it works is first the MHRA, which is Medicines and Healthcare Products Regulatory Agency. They will specifically look into whether the drug is safe, whether the drug is effective, and whether what the drug companies claim is it really reflecting, and also the impact of what it might be on the services. If they approve the drug, then it goes to NICE, which is National Institute of Health and Care Excellence. Their primary focus is, are these medications cost effective? Is it ethically, can be used with an NHS? So they will look at the similar things, but slightly from a different angle. Now, what are the problems? What impact that will have on how we deliver dementia services in the UK? We are really at a crossroads because this will have a huge impact on the services. So let's start from the whole patient journey, what it might be with the new medication. First is, who are going to be eligible for this medication? As I said, one of the criteria is that this medication, the patient has to have a lot of amyloid in their brain. Secondly, they have to be, these drugs, because they're disease-modifying drugs, they're not suitable for people who already have advanced dementia. So we are talking about people who either have very early dementia or sometimes people with mild cognitive disorder who, from a research point of view, often considered as a prodromal Alzheimer's. So we are talking about people way early in their illness trajectory. And maybe some of them are not having very many clinical symptoms. But to establish that they have a lot of amyloids in the brain, they have to go through very specialist assessment. So one is either what we call amyloid PET imaging. Now this amyloid PET imaging so far is only confined to very specialist centers. We are lucky in London that we have it in Imperial College. But across the country, there are only few centers which has got this. So that means that, not only these scanners has to be available way more, and also you have to have expert people who will be able to report. There is an alternative how you know the amyloids is by what we call CSF analysis. So that means what we call biomarkers. So, people can have lumbar punctures. Now, we obviously don't do lumbar punctures. We send them to the neurologist, but theoretically they can be done even in our service. So, lumbar puncture and then the analysis is being done to see these two things, amyloid and tau. We call them A beta, amyloid beta, and phosphorylated tau. And what happens in a classical Alzheimer's is amyloid beta goes down because the amyloid beta is sucked into those plaques, but because of the tangles, it actually releases the tau, so tau goes up in the CSF. But the problem is obviously this is an invasive procedure. It's putting a needle through your spine, and not necessarily everybody will be terribly excited about it. Now, there is some blood biomarker at the moment which is under trial. They're not in clinical practice. If that happens, things might be, in the sense you can just do a blood test and get the same result that you're looking for. So the first thing is to establish that, but it doesn't end in there. The problem is, we'll talk a little bit about these side effects called ARIA, amyloid-related imaging abnormality. But there is some evidence that some people who have a particular gene may be more susceptible to this side effect. Now, that particular gene, we call it ApoE4, that has been sort of implicated in a higher risk of Alzheimer's disease. So people who are positive for ApoE4 have a higher risk, and sometimes it runs in families. We don't do that routinely. But because there is a higher risk of ARIA in these groups, so technically people might need to go through that genetic testing before they can go on the treatment. So you can imagine already to get people into the treatment is quite a big cumbersome process. There's other things that who should provide the treatment. Should we provide treatment like every memory service should do that, or should we have what we call a hub and spoke model, where the spokes like the memory services, they will only identify people, and then there will be regional hubs who will actually do the specialist investigation and monitor the treatment. That is a possibility. But then the question is that then if that happens, one might say, well, what is then to do with the memory service? They will just see people and refer. No, it's not that simple, because once this treatment becomes available, there might be more demand, and we might be seeing people who are very early stage, and it has to be very skillful assessment to decide, because you don't want people to go inappropriately refer, but at the same time you don't want the people to lose out. So there will be an increased workload for memory services as well. And there is also an issue about capacity and concept. We presume, because these people are less impaired group, mostly probably they will have capacity. But do we have the expertise to actually explain them very well, the pros and cons and the dangers involved in the treatment? So that's also very important in the patient one. Now the treatment. Once you give the treatment, as I said, it's an IV infusion of a foreign protein. So that means you have all the risks of anaphylactic shock, other reactions, and things like that. So we have to have a setup where, this is IV infusion, monitored, who is going to monitor, what kind of expertise they need, how much backup we need about resuscitation and things like that if things go wrong. So that would be another issue, what kind of setup, what staff we need, and things like that, how long the infusion is going to do, how long the patient may need to stay in the place after the infusion. All those things need to be worked out in terms of treatment delivery. Also, this treatment is usually every 2 weeks, so the person has to continue. At the moment, the trials have gone up to 1 year. We don't know how long we have to give it. Is it something which is going to go with people for years? I mean, how convenient it is for people to come every 2 weeks to have an IV infusion and things like that. To make the matter even more complicated, we have this side effect which is referred to as ARIA, which stands for amyloid-related imaging abnormalities. What has been found is some people who goes for this treatment, they develop two different types of brain problems. One, they could have what we call cerebral edema, which is swelling of the brain, or they might have microhemorrhages. Now, the incidence is not very high, but there have been cases which have been fatal. Some people have died with serious brain hemorrhages or the brain swelling. Now, obviously, that's a very serious matter, particularly if you're giving a treatment in somebody who is almost asymptomatic. You're telling them we are trying to prevent you from developing dementia, and next thing they're dying. That will be, very difficult thing to sort of comprehend. again. So that means, that also needs to. Now that means what happens is drug trial protocols, they do an MRI scan every so altogether in a treatment, people have to have 6 to 8 MRI scans. Now we know how difficult it is these days to get an MRI scan and get it reported on time. So to have 6, 8 MRI scans in one spell of treatment and to have somebody with the expertise to report on those subtle changes is not an easy thing. And I don't think the current infrastructure of NHS can actually cope with it. So those are another thing we need to think about, how we are going to deliver safely and effectively this treatment, how we are going to monitor the improvement, who is best placed to do it. And I think that one of the things, going back to Jeremy's point, is that UK, historically and so far, UK is quite different in a way from particularly mainland Europe. Because UK, dementia treatment or care or diagnosis led by old age psychiatry. We do a more holistic thing rather than only an exclusive medical model. Whereas in continental Europe, it's often done by the neurologist and geriatrician. I'm not dividing line, but what I'm saying is that there is far more a medical model in continental Europe compared to the UK. We may have to balance, but also the question is how we are going to acquire these additional skills and how we are going to balance it properly so that we don't lose the good things, but we acquire the other things. And also the thing is that if this new treatment becomes very, very expensive, would it then suck money out of every other thing we are doing for people with dementia, people living with dementia? Well, I suppose, this is just to give you a balanced view, really, rather than just saying it's all glowing out there. But at the end of the day, the great news is that we are getting new treatment. There are a lot of new trials on the line, those focusing on amyloid and others. So I think, the whole horizon is probably going to change very significantly within 10 to 15 years. And recently we had a meeting, and one of the neurologists who worked with multiple sclerosis came, and they said this is like multiple sclerosis 20 years ago when new treatments came, and we had the same concerns and things like that. But the sort of it fine-tuned and it's changed the outcome in a great way. So we hope that is what will happen to dementia. We have mountains to climb. We have to climb it effectively, ethically, and equitably. But it's still an exciting time. So that's all from me today. Hope I didn't go too far over time. Thank you so much again for listening.
It was excellent, Sujoy, and actually perfectly timed, so thank you for that. Funny enough, I have to just share with you that I was involved in older people's mental health services back when Aricept was very first introduced, and in those days there was no treatment at all, medical treatment for dementia. And I remember some of those issues that you've highlighted being ones that we had to tussle with, and we were only allowed to put, I think initially, 3 patients in Hounslow on it, and how you decide who those people are and how you search it. Goodness, we've come a long way in 30 years, and it's very exciting to have some new potential treatments coming online. But it's interesting, so I just, you probably won't have seen it, but I think probably one of our carers has put something in the chat about the medication that her mother is on, and should the GP be prescribing some of these new drugs. So I think it's really important. I think he went on actually to emphasise that this is going to probably be quite a long process, both to get registration in the UK of some of these drugs, and then to think about how they are, people are assessed and put onto them, etc. But for me, as a non-medic, you really described it very, very well, and the way you get your tongue around those names.
Well, they are challenging, I'm telling you.
They were tripping off your tongue, and I was thinking, oh, they're a bit tongue twister. Thank you. We have got a couple of minutes, so to definitely take any further questions. People saying how good the presentation was. Anybody want to ask anything? This is your chance.
Sorry, Jo, I'll just come off the mic as well. I think within Rona's message in the chat, it was that her mother's taking Memantine, but I think earlier on in Sujoy's presentation, he's mentioned that it should be used with other medication, potentially with acetylcholinesterase inhibitor therapy. And she's asked, should the GP prescribe the drugs, like as mentioned, in addition to Memantine? So that's, I think, acetylcholinesterase inhibitor.
Yeah, thanks, Ryan. We'll comment later.
Just to clarify on that, the Memantine not necessarily have to be combined. two different mode of action, but that can be used by its own right. The two drugs, cholinesterase inhibitors and memantine, have got very different sort of side effect profiles. So in terms of choosing patients, we need to be very careful. There's been recent change in the NICE guideline, and the GPs are now allowed to start memantine, but often they don't. They kind of wait for us to tell them. But I'm sure what Jeremy was saying, that with more and more confident GPs, it is possible, particularly when the behavioral issues are there. But I think also GPs are very well placed, because often you want to rule out other factors which might contribute to behavioral problems like chronic pain or constipation and things like that, and then kind of choose memantine, make sure that the renal function is okay, and the GPs have access to all the medical records, so they're quite well placed in terms of making that decision. But obviously, sometimes it's about confidence and things like that, and the bilateral dialogue.
Thank you. There's one more question that's come in about how frequently old age country patients find themselves sectioned and visit to psychiatric wards, and I don't know whether you've got any comments on that.
It's relatively rare, we would say. I mean, sectioning, if you think, interestingly, like when I was a trainee, we used to have two inpatients unit only in Ealing, and then we have separate inpatient unit in Hammersmith and Fulham and in Hounslow. Now we have really two inpatient units, one in Ealing and one sort of semi-older people unit, which is in Hammersmith and Fulham, and that's capturing all three bodies. So overall, I would say that the admission number has gone down, and also in terms of the community sectioning is definitely less, but it happens. My experience is that definitely we are sectioning less number of people than we need, or involved into sectioning less number of people. And I think, that's probably the managers also are quite good, because they will be looking into it. But that's my reflection. I think it has got, to be honest with you, when the wards closed and the day centers closed, I remember about a decade back, I was thinking, oh my goodness, maybe we'll have, hell in the community. But I think we have managed that reasonably well. And the care homes also up their game. I think they manage people more difficult now than they did about 10, 15 years ago.
Oh, that's encouraging. And with our new chill service, hopefully even more.
Hopefully things will be even better.
Yeah, excellent. Thank you, Sujoy. There's one further question, which I think is probably more for the admin nurses, which was about whether admin nurses help guide with regards to power of attorney. I don't know whether we got any of the admin nurses still on the call. Lisa, are they with you, or have they gone back to work?
They've gone back to work, I'm afraid, but I think as far as I know, they will look at the carers' needs quite holistically. Oh, there's Claire. Claire's come back. Claire, I don't know if you can unmute.
Hi, yeah, they will certainly support and advise people with dementia and their carers around accessing power of attorney. And there's quite a lot of guidance on that on our website as well, with specific resources and leaflets, so people can be signposted to that and access that, or contact the helpline. But yeah, that would be an important part of it.
Okay, thank you very much. Right, spot on time, 5 minutes to go. I've got two things to do. Firstly, I think Sam is going to share a link for you to do an evaluation of this morning.